high mitosis, and this kind of epithelioid morphology, and GFAP showing glial differentiation, and there is BRAF mutation. So the differential diagnosis here would be obviously a anaplastic PXA and epithelioid glioblastoma. So we had to look for the salient clues here, the soft pointers which can differentiate between these two conditions. Otherwise, both can be seen in children and present with your seizure and all. So in this case, we also performed reticulin stain, and the tumor was completely reticulin poor, and we did not come across any xanthomatoid cells or any hyaline globules to indicate underlying PXA. So ultimately we diagnosed this case as epithelioid glioblastoma. So as Dr. Shilpa highlighted, these are in the spectrum of IDH wild type glioblastomas. So these are the subtypes, one of the 3 subtypes, and this is a kind of well circumscribed tumor. So if you see the radiology in this case, I can go back and show you. There it appears quite well circumscribed here, and as a very high grade tumor, and showing BRAF V600 mutation, which we further confirmed on by Sanger sequencing. So this is the epithelioid glioblastoma. The behavior of epithelioid glioblastoma can be. So this is anyway a grade 4 tumor and shows an aggressive behavior. So we saw 2 cases where there was epithelioid or rhabdoid kind of morphology, both in the supratentorial location. Now I'll go to another case, another child. This was a 4-year female again, history of ataxia and vomiting, recurrent vomiting. And on MRI, you can see a posterior fossa mass. So this is the cut in the cerebellum. You can see in the midline in the vermis region, there is a large mass with contrast enhancing, heterogeneously contrast enhancing, also pushing the fourth ventricle. You can see this midbrain here. So it is pushing the brainstem from posteriorly. And this was the histology. So again, you can see a tumor with a diffuse kind of growth pattern, quite highly cellular in dispersed small vessels. Again, you have this highly cellular morphology, kind mostly composed of undifferentiated embryonic cells with high NC ratio. Some are round, some are slightly elongated. In some areas, like here, you can see some rosetting. Like here, you can see some rosette formations. And there are some areas which is showing some spindling. Now, another focus where you can see this undifferentiated embryonal kind of morphology and some rosette formation here. And these areas are showing some spindling. So, and some cells with some vacuolization. So another photo where you can see these areas where this is very undifferentiated cells with readily you can appreciable mitotic figures, some necrosis, and these areas where we can see more of vacuolated clearing. So you can see here these areas where intermingle this undifferentiated cells, and in between you have these spindle cells showing some clearing. And if you look at these cells, they have again quite abundant cytoplasm, peripherally pushed nuclei, and some cells which are kind of elongated, they are showing abundant eosinophilic cytoplasm process here, and some cells showing this kind of vacuolization of the cytoplasm. Another photograph where you can see this kind of rhabdoid looking cells. So you can see this peripherally pushed nuclei, abundant eosinophilic cytoplasm, eccentrical nuclei, and this component was also showing frequent mitosis. So now what are we dealing with? So again, we did INI1 to rule out ATRT. We can see here both these components, this undifferentiated component and the other component which was showing this abundant eosinophilic cytoplasm, they are INI1 positive. So virtually excluding ATRT. Now synaptophysin, we can see these undifferentiated cell clusters which are positive for synaptophysin. However, these elongated cells with elongated cytoplasmic processes or these rhabdoid looking cells, they were negative for synaptophysin. So this area is losing a neural differentiation. Then this is desmin. So you can see here this elongated cells, the cells which were showing this kind of rhabdoid-like morphology are strongly positive for desmin. You can see nice cytoplasmic positivity here, taking a high power of desmin. You can see this kind of cytoplasmic positivity, and if in a high magnification, you can also see in this cytoplasmic process some striations, some alternate dark and light areas. So this indicates a rhabdomyoblastic differentiation, and this component was also positive for myogenin, which shows nuclear positivity. So based on these findings, the diagnosis would be a medulloblastoma with myogenic differentiation. So rare cases of medulloblastoma can show myogenic or melanotic differentiation, and these cases needs to be ruled out, should be differentiated from ATRT. So we showed you 3 cases which had a kind of epithelioid or rhabdoid kind of morphology. So with 3 different diagnoses. So this differential diagnosis should be considered, an appropriate immunohistochemistry should be performed for proper diagnosis. Now I'll go to my last case. So a 70 years male who
મેં પહેલા દિવસે પેમેન્ટ કર્યું 5102 જ છે કે નથી વધારે મારામાં.
Okay, so okay, so there is a 17 years male who presented with ataxia and progressive visual disturbance, and on MRI brain we can see a diffuse dural thickening with multiple broad dural based lobulated homogeneously enhancing lesion involving the falx cerebri, supra and paracellular region, and also entrapping the cranial nerves here. So a possibility of a meningioma was considered, an NPLAC type, and a biopsy was performed. So you can see this is the histology. We can see some pale areas and some dark areas. So we'll come to each individually. So on high magnification, you can see these pale areas and these dark areas. These dark areas you can see in the perivascular region, there is collection of lymphocytes and plasma cells. And in between, you have some collection of these pale looking cells. And you can see here this perivascular collection of lymphocytes and plasma cells, and here there are these cells which has abundant cytoplasm, eosinophilic cytoplasm. Some had this pink kind of new cytoplasm and some has this kind of vacuolated cytoplasm. However, if you look at the nuclei appears very bland of these cells. So another photograph where we can see these abundant, these large voluminous cells with abundant eosinophilic to pale or clear cytoplasm, and peripherally pushed nuclei, some have centrally placed nuclei, some multinucleated giant cells here, and the very bland chromatin, there is no there is no ATPI, no mitosis, no necrosis. And on a close inspection, you can see there are many of these large histiocytoid cells which are engulfing other cells, and they have a kind of halo around those lymphocytes, some plasma cells. So there's a halo. So this indicates there is emperipoiesis. So there are numerous foci which showed this kind of emperipoiesis in this case, and other areas also showed some fibrosis. We can see this kind of fibrosis which appears storiform at places, and some areas we also had this kind of plasma cell rich infiltrate. So based on these, the possibilities considered would be an inflammatory lesion. It could be a IgG4 related pachymeningitis, that hypertrophic type, or a Rosai-Dorfman disease, or also a clear cell meningioma was considered. So EMA was performed, which was negative. This is this is mislabeled, I'm so sorry. This is CD68, which highlights this histiocytes. You can see this histiocyte cytoplasm showing granular positivity for CD68. IgG4 was also performed, which was negative. And this is cyclin D1. Sorry, I'm extremely sorry for this mislabeling here. So this is cyclin D1. You can see this, all these histiocytes are showing strong nuclear positivity for cyclin D1, and they are also positive for S100. So the diagnosis in this case was a Rosai-Dorfman disease. So Rosai-Dorfman disease is a rarely involved meninges, predominantly the basal meninges, but it can also affect the convexities, and it shows radiologically, it often mimics a meningioma. But this emperipoiesis, presence of CD68 positivity and S100 positivity always helps. And nowadays, it is believed that cyclin D1 positivity indicates that the clonal nature of these histiocytes. So in this case also, all these histiocytes were positive for cyclin D1, thus further confirming the diagnosis. And most of these cases have a benign kind of course, but in view of increased plasma cells, it is also important to rule out a possibility of IgG4 related disease, and we ruled it out in this case by IgG4 staining. So with this, I finish my presentation. Thank you all for your patient hearing, and I think I'll finish here. Thank you, organizers, once again.
You show us the approach to rare cases, because sometimes some uncommon cases can present as a common diseases. You show us a first case of ATRT, atypical thyroid tumor. So how to approach tumors presenting with small round cells. You show us that diagnosis should not be based on a single marker or morphology alone. It should be comprehensive diagnosis based on radiology, morphology, and multiple IHC markers. Then
right. So basically what happens, as I told, sometimes you may not get these rhabdoid cells. If they are there, they help you to cleanse the diagnosis. But sometimes you may not get those typical rhabdoid cells on histology. So it is important to keep your mind open and do a panel of immunohistochemistry. And if you have INI1 loss, then it definitely confirms. But even if it is present, but you are strongly suspecting ATRT, and retained INI1 does not rule out. But you have to remember that there are other differential diagnoses that, as I showed you that case, epithelioid glioblastoma, those cases should also be kept in mind.
So your second case was also interesting, in which you show how to approach a tumor with polygonal cells, epithelial polygonal cells, because
Right.
this morphology is present many other tumors, like SEGA, PXA, or rhabdomyosarcoma. So it should be based on multiple IHC markers. Your third case was also interesting, of medulloblastoma with myogenic differentiation. It's a very rare differentiation of medulloblastoma. So it should be keep in mind, medulloblastoma should be kept in mind whenever you found Desmond positive in a embryonal tumor. And sir, your fourth case was really very interesting. I have heard it for the first time, Rosa document disease, which was presented radiologically as a meningioma. So definitely, these rare cases are going to be very helpful for all the listeners. Thank you very much, sir.
Thanks. Thank you very much.
Now I would like to invite our next speaker, Dr. Paramita Paul from BHU. She will discuss the utility of squash cytology in CNS tumors. Welcome, ma'am.
So is my screen visible and am I audible?
Yes, ma'am, your screen is visible. Yes, ma'am, you can start.
Okay, so the topic assigned to, good afternoon, everyone. The topic assigned to me was the utility of squash cytology in CNS tumors. Now, the squash cytology is one of the first-hand specimens a resident gets to see in a neuropath lab, even before seeing the histo slide. And the interpretation of cytology is as good as histopathology. So if one's histopathology is good, his or her interpretation of squash cytology will also be good. So with this background, I'll begin my talk. Now, it is always good to dwell into the history and see who has done something. So the interpretation of intraoperative smears that dates back to 1930, and the credit goes to Dr. Louis Eisenhardt, who was the neuropathologist then and one of the renowned neuropathologists of our time, and Dr. Harvey Cushing, who we know is the father of neurosurgery. So he had some primitive methods also of neurosurgical methods, like he used to open up the brain just to let loose the tumor so that it doesn't compress the adjoining tissue, because at that time the stereotactic biopsy or endoscopic surgery was not available. So why squash? If we have a frozen section in our department, why to do a squash? That is because human brain is mostly composed of water with a little bit of lipid and protein. So it's liable to get more artifacts if we freeze the tissue. Besides that, the other advantages are it's a simple and rapid methodology. Additional tissue can be used for ancillary techniques, and it can decide on the extent of resection. So what are the techniques used? So basically 3 techniques can be used. One is the touch preparation, where we just touch the tissue with forceps into the slide. This can be advantageous in loosely cohesive tissues like the pituitary adenomas and the lymphomas. However, the tissues like the glial tumors or the tumors with increased reticulin, they will not give a good result. The other method can be a squash preparation, where we just put the tissue between 2 slides and just press upon it. In this, the disadvantage is that we will have a central blob of tissue which is of no use. However, the periphery can be used for interpretation. It can be used in cases in some glial tumors. But the method which is mostly used is the squash and smear technique. That is, we squash the tissue and then pull apart the slides and we get a gradient of a smear. Now, when we prepare a squash, what are the things we have to notice? We have to notice whether the tissue squish very easily. That means it is either a discohesive tumor process or a normal brain. Does the tissue come apart but with a bit of effort, like that is typical of most gliomas and some metastatic tumors? Is the material firm during squash, or does it shoot out from the tissue between the glass slides, like the tissues which have increased fibrosis or increased reticulin, like the meningiomas, schwannomas, or desmoplastic metastasis? When we sample, we have to first observe the tissue. The basis of pathology is observation and then interpretation. So first of all, we observe the tissue and find what all different areas are there. Some hemorrhagic areas, some yellow areas, some whitish areas. So it is good to sample each and every different looking areas. And then prepare the smear. So at least 2 slides should be prepared. And after preparing the slide, it should be immediately fixed in alcohol. So after smearing, after preparing the squash, we get a smear of this sort. So what are the critical steps? First and foremost, observe the tissue and sample everything that looks different. Touch the tissue until it heals, but not beyond that, because if we give more pressure, then there's likely to damage the nucleus and there'll be shearing artifact. But it should not be too less of a pressure, because we have to break the matrix. Otherwise, we will not get any good smear. Pull the slides apart with the same force as the crush, smoothly but rapidly, and immediately immerse in alcohol. So this is the staining technique which is used, which is a rapid staining method. So after immediately fixing in alcohol, we dip in hematoxylin for 1 minute, and then we do the bluing by running in running water and bluing in lithium carbonate 1 dip. Wash again in running tap water, eosin for 15 seconds, dehydrate in alcohol for 2 changes, and then clear in xylene 2 changes, and then mount with DPX. Next, coming to the examination of the smear. Now, even before examination of the smear, we have to have a well-filled requisition form containing the history, because the history also gives a lot. Like if the patient is a child, then we will suspect either an embryonal tumor, or it can be a pilocytic astrocytoma if the location is in the posterior fossa. Similarly, a diagnosis of choroid plexus carcinoma should never be made in an adult, because this is predominantly found in the children. So this is the importance of age. Then the duration. How long is the history? Now, a patient complaining of long-standing seizure disorder is not likely to have a high-grade glioma. But there can be surprises, but still these are the common instances. Next is radiology. We should have good radiology friends for interpretation, because they can help us a lot. So from radiology, we can get the location, whether it is intraaxial or extraaxial, dural involvement is there or not, because the dura-based tumors like meningiomas and the PXAs can also show dural attachment. Then the extent of the tumor, edema, enhancement, because in glial lesions, the enhancing glial lesions are most likely to be high-grade gliomas. Next is the gross examination. Grossly examine the tissue, whether it is hemorrhagic, whether there is any pigment or not. Like a hemangioblastoma will show areas of hemorrhage. A melanoma will show melanin, a black-brown pigment. Then when we physically separate the tissue, then also we can get some clues. Like if there is hindrance of separation, means there is some desmoplastic reaction that can be a PXA, or it can be a meningioma, it can be a schwannoma. If there's some gritty sensation, means there's some calcification, that can be a pseudomonas meningioma. So each and every aspect is important. Gross examination. After staining also, we can hold on to light and see how is the appearance of the slide. Now, any blue appearance means there is increased cellularity. It can be an embryonal tumor. The pink appearance can be seen in a normal brain tissue or glial tumors. Whether it is lumpy or smooth. Lumpy means it's not adequately smeared, which can be found in meningiomas, schwannomas, or the smear is smooth, like there's a smooth gradient in pituitary adenomas, lymphomas. Then in intermediate magnification, the matrix becomes clear, whether it's glial, it's liquid type, epithelial, or cohesive. In high power, the cell reveals their identity. From cytoplasm, we can get hint of the cell type, and the nuclei gives a hint whether it's reactive or neoplastic, benign or malignant. Now, the best area of examination is this area C, when the cells are still touching each other and it is the cytoplasm and nucleus is not sheared off. Now, microscopic examination, the smear evaluation, these parameters are being evaluated. I will discuss them one by one. The type of smearing, the type of background, type of blood vessels, any presence of specific cell groups, predominant cell type, presence of specific cellular elements. So the type of smearing, the non-cohesive lesions like the normal brain, pituitary adenomas, lymphomas, melanomas, metastatic small cell carcinomas, they will show an even gradient while smearing, and the cells will be individually dispersed. Like this is an example of a pituitary adenoma. Epithelial tissues we know have desmosomal attachments, and so they are difficult to shear. So they'll be in blobs, and there'll be some connections between the cytoplasmic connections between the cells. Like this is an example of a metastatic epithelial lesion. So in this low power also gives a hint. It is not as smooth, and we can see this blobs of tissue. Then glial lesions, the glial processes can be seen. The smearing will be like the appearance is like a spread apart cotton wool appearance, like we can see here. And the glial processes can be evident, especially in reactive lesions and in tumor process. In cohesive lesions, again, as they are well connected by the connective tissue, like in schwannomas, meningiomas, and hemangioblastomas, they resist shearing. However, sometimes, like in this smear, in this we cannot interpret anything. It is a lost case for a neuropathologist. However, some of the tumors can, even after that, shear some cells. So some of the cells is still visible, and a diagnosis can be made. And if it is absolutely impossible to make an interpretation, then one should go for frozen section. Now coming to type of background. The background can be finely granular, as can be seen in this neuropil-like background, where we can see this fine granular background. It can be clear, like clear empty spaces can be seen in tissues like meningioma and hemangiopericytomas. Fibrillary background is seen mainly in glial tumors. This glial fibrils are seen. Necrotic background can be seen in high-grade gliomas like GBMs or abscess. Granular vacuolated granulomas, like background that is seen in the stigroid background in germinomas. Or we can get myxoid background in various tumors like the D-nets, in some pilocytic astrocytomas and pilomyxoid astrocytomas. Next, coming to blood vessels. Now, thin-walled blood vessels, they can be found in low-grade gliomas, neurocytomas, D-net. Thick-walled hyalinized vessels can be seen in schwannomas, and microvascular proliferation that they can be found in glioblastomas. A network of vascular channel like here, this can be seen in hemangiopericytomas with these blood vessels and tumor cells attached to it. These are thin-walled blood vessels which are seen in low-grade gliomas and and this is an example of ganglioglioma. And this is an example of microvascular proliferation, florid microvascular proliferation in glioblastomas. Now, tumor distribution can also be seen in relation to blood vessels, like a perivascular gradient pattern. The tumor cells are arranged perivascularly in anaplastic astrocytoma. Angiocentricity is found in lymphomas, and randomized clusters around blood vessels can be seen in metastatic tumors. Specific cell groups, like these groups can be found in smears like whorls can be found in meningiomas, papillae like in choroid plexus papilloma, papillary tumor of pineal region in some metastasis, and various types of rosettes can also be found in embryonal tumors, ependymomas, astroblastomas. Then type of cell, ganglion or ganglion-like cells, they can be found in ganglioglioma. Round cells can be found in germinomas, oligodendroglioma, pituitary adenoma. Epithelial or epithelial-like, this can be found in metastasis. Fusiform or spindle-shaped cells can be found in nerve sheath tumors, SFTs, pituitary etc. Then small polydifferentiated morphology can be found in embryonal tumors, and mixed morphology can be found in glioblastoma, teratomas, or ATRTs. Then specific cellular elements, background cellular elements like Rosenthal fibers, they can be found in pilocytic astrocytoma, ganglioglioma, then pyloid gliosis, or Alexander's disease. Eosinophilic granular bodies, this can also be found in pilocytic astrocytoma, PXAs, like this is a eosinophilic granular body. Keratin, that can be found in craniopharyngiomas, like this is an example of wet keratin. Apart from that, we can find keratin in epidermoids and squamous cell carcinoma. Lymphoglandular bodies, as we all know, is found in the background of lymphomas. Then melanin can be found in case of melanomas or melanocytomas. And mucin can be found in metastasis or some gliomas with myxoid degeneration. Then the location also gives a hint, like cerebral white matter. If the tumor is located in cerebral white matter, means we are most likely looking in glial tumors. Then periventricular location, we might be looking in a CNS lymphoma. Metastasis is mostly found in the gray-white matter junction. Choroid plexus, means the tumor can be a choroid plexus papilloma. If it's a posterior fossa tumor, it can be a medulloblastoma or a pilocytic astrocytoma. Then ventricular tumors can be ependymomas. So all these aspects are important. Now, before going to the tumors, a brief about the normal brain. Now, gray matter shows smooth, relatively pink smears, and we can find some neuronal tissues and their synapses, and some delicate capillaries can also be found. White matter is again hypocellular. We can find a mixture of cells, the round oligodendrocytes and some astrocytes. Cerebellum, this is a major site of confusion, especially when the internal granular layer is smeared, because this can mimic an embryonal tumor. However, if you find a Purkinje cell neuron apart and along with neuropil, then we can be sure that we are looking into a normal cerebellum. So these are the normal brain tissue and potential misdiagnosis that one can make. White matter can mimic a low-grade glioma. Gray matter, one can, as we can find neurons in gray matter, one can confuse with mixed glioneuronal tumors. Cerebellar cortex, as I have said, if the internal granular layer is being smeared, one can confuse with embryonal tumors or lymphomas. Choroid plexus, normal choroid plexus, one can confuse with choroid plexus papilloma. If one smears the arachnoid granulations, then one can confuse with meningioma. Pineal gland in children can be confused with pineocytoma, and pineal gland in adults, low-grade glioma. So with this background, I'm coming to the brain tumors. Now I have discussed the brain tumors in a case-based approach, and these are not original cases. The pictures has been taken from textbooks, and these are virtual cases. So suppose a 28-year-old man presented with repeated convulsive attacks for 1 year with a sudden episode of right hemiparesis. And the T2 and gadolinium, this T2 is showing some hyperintensity with some smooth contour. The sulci and gyri is not that visible, and there is no enhancement. Means likely we are looking in a low-grade glioma. So low-grade glioma will show somewhat increased cellularity. This is a reactive brain. This also is showing somewhat increased cellularity, but still the cellularity is much more increased, and we can see the cells are enlarged. And the key to this making a diagnosis of glioma is the cells will be uniformly pleomorphic, means all the cells will be pleomorphic. While in case of a reactive lesions, we can see a mixture of cells, even though the cellularity is increased. So this is a histopath section. This is astrocytoma, the grade 2. Coming to the next case, this is an elderly patient admitted to the hospital with a short history of hemiparesis and disorientation. Now in this, we can see there is a tumor which is showing a lot of edema, and there's a ring-like enhancement in the gadolinium. So this is most likely a high-grade glioma, as it is showing enhancement. So on smear, we can see the cellularity is increased. We can see some blood vessels here, and the tumor cells are clinging to the blood vessels, and we can see a lot of pleomorphic cells, some gametoscytes and some pleomorphic cells. So this is a hint that this is a glioblastoma. This is just to compare with the normal brain, which was also present in the smear. We can see the difference between the normal and the abnormal. This is showing the microvascular proliferation, as I have already discussed. These are features of glioblastoma. Next case, a 30-year male presenting with 1-year history of seizure, which is refractory to treatment. And it is a cortical-based tumor, which is also showing extension to the white matter, but there is no enhancement. Again, it points to a low-grade glioma, and it is cortical-based, extending to white matter. So maybe the white matter tumor of white matter. So we are seeing this largely monomorphic tumors in smears, somewhat speckled type of chromatin, and some cells with this eosinophilic cytoplasm. These are micro or mini gemastocytes. This is most likely an oligodendroglioma. Then coming to a 10-year male who is presenting with occipital headache, nausea, vomiting. So this is a posterior fossa tumor, and this is a solid cystic tumor. This is a solid portion which is enhancing on gadolinium. So the likely diagnosis in a child with solid cystic tumor can either be a hemangioblastoma or pilocytic astrocytoma. So with this backdrop, when we look into the smear, we will see that this is again showing a glial tumor, cotton woolly appearance. Some thin walled blood vessels are seen, and we can see these elongated pyloid cells and this Rosenthal fibers. And this is again a multinucleated cell, which is this is called a pennies on a plate appearance. So this is the histopath showing this solid microcystic area, solid cystic tumors and Rosenthal fibers. So this is a case of pilocytic astrocytoma. Then a 28-year-old male presenting with sudden limb twitch, visited to a local hospital. So this is again a solid cystic tumor. This is T2 hyperintense lesion, and a small enhancing nodule is seen. And this smear we can see is difficult to smear because of some desmoplastic reaction. It is not like the earlier smears, which were quite easy to smear, and we got a cotton woolly appearance. And we can see these pleomorphic cells, some eosinophilic granular bodies, and some lipidized cells. This is the histopath section showing increased reticulin deposition, fascicles of these pleomorphic cells, and some lipidized cells. So this was a case of pleomorphic xanthoastrocytoma. Now, pleomorphic xanthoastrocytoma can easily be misdiagnosed as a high-grade glioma because of the presence of these pleomorphic cells. So we should look into the history, like solid cystic lesion associated with the history of seizure. So most likely we are looking into a pleomorphic xanthoastrocytoma. Then a 30-year male presented with headache, nausea, and vomiting. Again, this is a posterior fossa lesion and showing some irregular contrast uptake. So this is showing increased blood vessel proliferation, and tumor cells are again clinging to this blood vessels. And the appearance is that of a salt and pepper chromatin. So this is a ependymoma. This is again showing this comparative between the smear and histopath section. We can see these blood vessels and the tumor cells with the radiating glial fibrils around the blood vessels. Now, another case, a 7-year-old boy who is presenting with 2-month history of decreased activity, with loss of interest in his surroundings. And what in the MRI, what we can see is this cauliflower-like growth, which is brilliantly enhancing. So this is again a ventricular tumor. This is a choroid plexus papilloma. We can see these papilloid fragments with these fragments coming out of the main papilloid fragment. This can be confused with the normal choroid plexus, but the clue to the diagnosis would be a nuclear overcrowding and mild nuclear enlargement. Apart from that, we can see calcifications also. Now coming to the neural and primitive tumors. Say a 15-year male child presented with several year history of temporal lobe epilepsy, including auras of noxious smell. So on MRI, we can see a solid cystic lesion again. It's showing T2 hyperintense cystic lesion, and which is showing a small nodular enhancement. We can see these blood vessels, thin-walled blood vessels, not thick-walled blood vessels, Some lymphocytes are there, some polymorphic population is there. And in this power, we can see this large ganglion cells, which are better appreciated in this high power. So these are dysplastic ganglion cells with prominent nucleoli, irregular aggregation near the plasma membrane of the nasal substance, and aggregates of this ganglion cells. So this gives a clue that we are looking into ganglioglioma. Now this is histopath section, again showing perivascular lymphocytes, this ganglion cells. Next case, a 17-year-old male having bipolar and general anxiety disorders. Again, we can see this temporal lesion, which is showing some flared hyperintensity. That means it is not water, it is something else. However, it was not enhancing on contrast. So again, we are looking into a low-grade lesion. So this is showing a myxoid lesion, and we can see the tumor cells are arranged in columns with some floating neurons. Again, we can see this thin-walled capillaries with some linear arrangement of this round oligodendrocyte-like cells and this floating neurons in histopath. So this is example of this DNET. Next case, a 25-year-old female presented with radiology department with complaints of headache. So we can again see a ventricular tumor, which is abutting the septum pellucidum as well as the lateral ventricle. A solid cystic tumor, which is showing irregular contrast enhancement. So this is again showing a gradient of smear, a regular gradient with uniform cell population, round cells with somewhat salt and pepper chromatin. And on histopath, it was found to be synaptophysin positive. So this is an example of a neurocytoma. Again, a 2-year-old boy with gross motor delay presented with unsteady gait, again a posterior fossa lesion, relatively well circumscribed, somewhat showing enhancement. Again, this is an embryonal tumor, which is showing, which is very cellular, showing this salt and pepper appearance of the tumor. Some acinar arrangement is also there. And on histopath, we can see this mitosis and this small round blue cell tumor. So this is an example of medulloblastoma. Coming to hematological tumors, so these are basically lymphomas. They can be primary or secondary. Suppose a 71-year-old immunocompetent female presented with progressive ataxia, imbalance, and dizziness for 1 year. MRI is showing this lesion, which is this central part is somewhat hypointense. However, it is showing enhancement with some perinodular hyperintensity. This is because of the diffuse spread of the cells. So again, this is showing a uniform gradient of cells, monomorphic appearance of cells, some lymphoglandular bodies, and brisk mitosis on histopath. Now in squash smear, it is difficult to see mitosis as they are likely to be damaged while smearing. So this is an example of high-grade B-cell lymphomas. Now the caveat in lymphoma is that in treated brain lymphomas, because the clinical interpretation can also be like that of multiple sclerosis, or can be like acute disseminated encephalomyelitis. And when the clinician also doesn't have a knowledge of this, they are likely to treat the patient with steroids. So these are the cases which pose difficulty. And in this, we can see a mixture of say microglial cells and some lymphocytes. In that case, histopath can only clinch the diagnosis with immunohistochemistry. Otherwise, it is very difficult to clinch the diagnosis in a squash smear. Now, lymphomas can be primary and secondary. The primary lymphomas have a periventricular location, or it can be in the gray-white matter junction, while in case of peripheral lymphomas, they are located in the subarachnoid space or the Burkow-Robin space, or can have intravascular lymphomatosis. Now coming to some extraaxial tumors, the meningiomas and the schwannomas. In this we can see MRI, which is showing a dural tail with uniform hyperintensity. Aggressive lymphomas show more of edema and shift of the brain. So meningiomas are also sometimes difficult to smear. However, at times they show off some cells at the periphery. So one can see the whorls, and also the cells are largely uniform, and they'll be connected by this strands of collagen. Besides that, sometimes we can see this whorls and some inclusions also. So this will lead to a diagnosis of meningioma. In psammomatous meningioma, we can see this laminated concretion of calcifications, especially found in spinal locations. Next case, a 40-year female presented with asymmetric hearing loss, tinnitus. In this, we can see the tumor is located in the region of the 8th cranial nerve. The tumor is seen to arise from the 8th cranial nerve. And this is an example of schwannoma, again difficult to smear, but some cells can be identified in the periphery and clinging to the blood vessels. The higher power can show this spindle appearing cells, and some degenerative atypia can also be found. Coming to some regional tumors. Now, this is an example of pituitary adenoma attached to pituitary stalk. Again, this uniform gradient can be seen. The tumor cells are largely monomorphic, well separated. The pituitary can sometimes present with pituitary apoplexy, when we can see a necrotic tissue surrounded by a rim of enhancement. These tissues are again difficult to smear, and we can see this ghost outline of this monomorphic tumor cells. Next case, again a cellular supracellular tumor. This is again a solid cystic tumor. And in smearing, we can see this blobs of tissue. These are epithelial fragments. And on high power, we can see these folded tissue fragments, which are appearing basaloid to squamoid in appearance. Then we can look into the wet keratin. This is the histopath section of the same. So this is a diagnosis of craniopharyngioma. This is a case of craniopharyngioma. Another case which can be found in young children is the germinoma, where we can find a mixture of these large cells which are admixed with the small lymphocytes. This can again be a cellular supracellular tumor. Next case, a 30-year male presented with ataxia and hydrocephalus. Again, a posterior fossa solid cystic lesion with an enhancing nodule. Difficult to smear. There's a normal cellular tissue, however, it is showing a lot of hemorrhage and cautery artifact. The clue to the diagnosis is this pleomorphic appearing stromal cells and some vacuolated cells. However, sometimes we have to hunt for these cells in a smear. So this is a diagnosis. This was a case of hemangioblastoma. Next case, a 40-year female presented with 2-year history of worsening lower back pain and sciatica. This is a well circumscribed nodule which is showing uniform enhancement. Again, we can see this uniformly spread tumor with salt and pepper chromatin and some eosinophilic cytoplasm. In histopath, we can see this Zell-Balin pattern. This is a case of paraganglioma. Now, this miscellaneous other tumors I have put. This is a case of pineoblastoma. We can see this rosettes, pineocytoma. We can see this uniformly spread tumor. Then papillary tumor of pineal parenchymal region, showing this papillary fragments. Melanoma, which is showing this dispersed population of cells, highly pleomorphic cells, prominent nucleoli, some inclusions, and some melanin pigment. And lastly, metastasis. Again, we can see this blobs of epithelial tissue. We can see this epithelial fragments and the cells connected by this cytoplasmic process. Chordoma can be present in the clival region. So this is a myxoid appearing tumor. So we can see these cords of cells, and sometimes we can see the vacuolated cells, that is the phyceliferous cells. Sometimes the chondrosarcoma also comes in the DD of the chordoma. So coming to the last slide, what are the advantages? This is cost effective, rapid and technically simpler. Small amount of tissue is needed. Better preservation of cellular detail as compared to a frozen section. Best for demonstration of fibrillary cytoplasmic process, provides additional information to permanent sections, and avoids the artifacts of frozen section and contamination in case of infections. The limitations, the tissue has to be soft enough to be smeared, because the tissues with desmoplastic reaction or some meningiomas and schwannomas, they can be difficult to smear at times, or even some tissues with infectious pathology. Then we have to go for frozen sections. Again, tissues with extensive collagen and reticulin, they are difficult to smear. relies on accurate localization by the surgeon. Sometimes it is difficult for the surgeon to differentiate between the normal glial tissue and the tumor, especially in low-grade glioma. So we are dependent on their accurate localization, and we can misdiagnose some high-grade glioma when they are sampling some infiltrating front of glioma. We can misdiagnose that as low-grade glioma. Difficult to find mitosis in smear, and specific training is needed. So these are my references. And thanks to the organizers for inviting me to giving the talk. This is the photograph of morning aarti in Varanasi. And this is TMH, which I have recently joined. So thank you. Thanks for patient hearing.
Thanks for such a lucid and informative session on squash cytology, its utility, technique, and approach to form a diagnostic report were thoroughly discussed. And also, we should keep in mind various points to prevent the misdiagnosis. The cases also which you discussed were very enlightening, ma'am. Thanks a lot.
Thank you. Thanks a lot.
Now we'll move on to our next presentation by Dr. Richa Singh Chauhan. She is Assistant Professor in Department of Radiodiagnosis, AIIMS Raipur. She has pursued MD DNB Radiology and DM in Neuroimaging and Interventional Radiology from NIMHANS. She has also completed a fellowship from Royal College of Radiology in UK. Today she is going to deliver a talk on neuroimaging in the era of recent CNS tumor classification. Welcome, Dr. Richa.
Thank you, Dr. Garima, for the kind introduction. So today I will be talking about neuroimaging with respect to the newly come CNS tumor classification that has come in 2021, and that has given many changes in the gliomas, preferably, and the embryonal tumors. And the first WHO classification actually came in 2007. After that, so many changes have happened over the years. In many updates and many versions of the WHO classification of CNS tumors have come. But the previous versions of the WHO classification of CNS tumors, they preferably incorporated histological diagnosis and histological classification. The 2016 classification, for the first time, it incorporated the molecular or the genetic basis of CNS tumors within the classification, and the further advance or the further upgrade in that version, that is the 2021 CNS tumor classification, has also incorporated many molecular subtypes of tumors within the classification, and correspondingly, the imaging of the tumors, these CNS tumors, has also underwent many changes, and the radiogenomics has come up over last few 5-6 years, and a lot of work has been done in radiogenomics, which is basically a science where the imaging of the tumor is used to identify the genetic background or the molecular subtype of the tumor. So the role of radiology in the diagnosis or the molecular diagnosis of the tumor has also come up with the upgrades in the WHO classification. So the WHO classification, the recent WHO classification, actually it divides the CNS tumors in many groups, but the major changes that have come up are there in the gliomas, glioneuronal and neuronal tumors, ependymal tumors, and embryonal tumors, and other tumor groups have undergone either minimal changes or no changes at all when we compare them as compared to the 2016 WHO classification. So I will be talking only about the update and the newer imaging features which have come up after the 2016 WHO classification. So first, let's see about gliomas. There are approximately 14 newly recognized gliomas and glioneuronal tumors in the recent edition. And this is for the first time in the WHO classification that age has been given importance in the diagnosis and in the classification of gliomas. So based on age, the gliomas have been divided into adult type and pediatric type gliomas. And it is very important to know because the different genetic markers or the gene mutations, they also differ in various tumors, and that also depends on the age. So there are 4 major subgroups of diffuse gliomas in the brain. And those gliomas have been divided into 4 major groups, that are adult type diffuse gliomas, pediatric type diffuse low grade gliomas, and pediatric type diffuse high grade gliomas. And then there is a 4th group with the other circumscribed astrocytic gliomas, as compared to the 2016 classification, in which they were classified as other astrocytic tumors or other gliomas. So the first group, that is adult type diffuse gliomas, have been further subgrouped into astrocytoma IDH mutant, ODG or oligodendroglioma IDH mutant, and ODGs are also characterized by 1p19q co-deletion. And the third group is GBM IDH wild type. So I will not be going into the detail that what is the difference between the 2016 and 2021 version in the pathology, because that has been already covered in the previous lectures. And I will be directly going to the imaging. So the imaging feature of IDH mutant diffuse astrocytoma, that is a grade 2 or the lowest grade tumor. It's a very simple looking tumor, a very homogeneous T2 player hyperintense tumor, circumscribed tumor, no diffusion restriction, no high perfusion will be there in the tumor. There will be no enhancement. So it will be a simple looking tumor. The patient usually presents with either headache, simple headache, or it will be an incidentally detected lesion, or the patient will present with seizures. So these tumors are usually seen in the younger age group. And there is a imaging sign, that is T2 flare mismatch sign, which is highly predictive of IDH mutant diffuse astrocytoma. And it is so significant that it has very high specificity of the order of almost 100%, but the sensitivity is low. So let's see what is this T2 flare hyperintense sign. So what we are seeing here is a left frontal tumor centered in the middle frontal gyrus on the left side. And what we are seeing here is a T2 hyperintense lesion, which is very well defined, limited to the cortex. Not much infiltration into the white matter is there. There is not much edema around the lesion. It is very well defined with very smooth margins. But what we are seeing on flare here is that the hyperintensity on the T2 is not replicated on flare. Instead, the tumor not being cystic, but still what we are seeing here is flare hypointensity within the tumor. So this is what is known as T2 flare mismatch, because ideally, because of the water content of the tumor is supposed to be hyperintense both on T2 and flare. But this is a characteristic feature of IDH mutant diffuse astrocytoma, that it would be showing T2 flare mismatch, that is, it would be hyperintense on T2, but hypointense of flare. Also, there would be a flare hyperintense rim around this tumor. So this sign is very specific for IDH mutant diffuse astrocytomas. Another example, another lesion centered in the right frontal lobe, very bright on T2 hyperintense, again hypointense on flare with a flare hyperintense rim. Another example, an insular glioma located in the right insula, T2 hyperintense, flare hypointense with a hyperintense rim on flare. So this sign is very specific for diffuse astrocytomas that are IDH mutant. Then in our reports also in radiology, as the pathologists, they are supposed to write a layer diagnosis, a structure diagnosis. And we also in radiology nowadays practice this layer diagnosis. If we are able to tell the molecular definition of the tumor, then we also incorporate that in our radiological report. So the other diffuse astrocytoma in the adults is IDH mutant diffuse astrocytoma grade 3. So grade 3 and grade 2 lesions, they don't have so much of difference on imaging, but if a lesion is showing hemorrhage, is showing somewhat of necrosis, not much necrosis, some minimal to moderate enhancement, then the lesion would be graded as grade 3. Even on the imaging, we can write the diagnosis as grade 3 astrocytoma. And the tumor will be heterogeneous as compared to the homogeneous tumor, which I showed you previously. If we do the perfusion imaging, the blood volume within the tumor will be very high, and it will be higher as compared to the grade 2 tumors. And the ODG, there is not much change in the imaging of ODG. Even after the description of these mutations within the ODG, the typical ODG, which is a cortical-based tumor with calcifications and heterogeneity, the imaging remains the same. So these are the 3 examples of diffuse astrocytomas here. And let's see, so these first 2 are the flare and the post-contrast T1 weighted images. What we are seeing here again, a flare hypointense lesion with a hyperintense rim. So the T2 is not given, but the lesion was showing T2 flare mismatch. And as I told you earlier, in the diffuse astrocytoma low grade, that there is no enhancement usually. So this lesion is also showing no enhancement. And on histopathology after resection of this tumor, it was found to be grade 2 astrocytoma. So another example here also we can see that this lesion is there, which is again central flare hypointensity with peripheral hyperintensity is there. There is no much enhancement on post-contrast images. Again, a grade 2 tumor, a grade 2 diffuse astrocytoma, IDH mutant it will be. Another tumor, a third tumor, we can see that the tumor is showing flare hyperintensity. Again, it is very well defined. It was showing some blooming foci on the SWI images. The image is not shown here, but if we see on the post-contrast image, what we are seeing here, that there is patchy minimal enhancement within the lesion. So on imaging also we can say that it is not now a low-grade tumor. The grade is high because the tumor is showing enhancement. And on histopathology and on pathology, it was found to be a IDH mutant grade 3 astrocytoma. So that's how we differentiate between a grade 2 and grade 3 tumor on imaging. Now, let's come on to the pediatric type diffuse low-grade gliomas. They are further subtypified into diffuse astrocytomas and angiocentric gliomas. Then this is a new entity, that plenty, that is polymorphous low-grade neuroepithelial tumor of the young. And then there is this fourth entity, that is diffuse low-grade gliomas. These 2, third and fourth entities, they have MAPK pathway alterations pathologically. So the diffuse astrocytoma, it is usually seen as a DIPG sort of conventional imaging description of a pontine glioma, where again the glioma will be non-enhancing, non-high perfusing, non-diffusion restricting, a simple benign looking lesion which is just expansile and expanding the pons. That kind of picture will be seen in these astrocytomas that are MIB or MIB-L1 altered. Now, angiocentric gliomas, they are a T2 hyperintense mass. As we can see here in this case, there is a T2 hyperintense lesion. It's a cortical based lesion, and it will be a benign looking lesion in a pediatric age group. This is the image of a 7-year-old child who presented with seizures. So angiocentric gliomas usually present with seizures, and we can see that it's flare hyperintense. There is no enhancement on contrast, and this is ASL, that is arterial spin labeling, which is a type of perfusion MRI, and we can see there is no high perfusion within the tumor. The high perfusion will be seen as brightness on ASL, so which is not seen. So this is an example of angiocentric glioma. This tumor, again, as I described earlier, the expansile pontine tumor, it is an example of diffuse astrocytoma, MIB-L1 altered. Now, this is a new tumor entity in the classification of gliomas, which is plenty, polymorphous low-grade neuroepithelial tumor of the young. It's a very characteristic lesion which is typically seen in temporal lobe mostly, and patients present with seizure. They are mostly young patient. The lesion is usually T2 flare hyperintense, again well-defined lesion, no enhancement because it's a low-grade lesion again. So no enhancement, no hyperfusion, no diffusion restriction, and it will be a simple plain benign looking lesion grossly on imaging. So here is an example. There's a tumor sitting here in the superior temporal gyrus on the left side, and there is no enhancement in this lesion, as we can see here. So this is an example of plenty. Another example, the temporal lobe lesion. The lesion is centered in the right parahippocampal gyrus. What we are seeing here, there is a central calcification, which is very typical of this polymorphous tumor. It's a flare hyperintense lesion. And on SWI image, it is showing multiple punctate blooming foci, which could suggest hemorrhage also. And the central chunky one depicts this calcification, which we are seeing on CT. So this central calcification, if we are seeing in a temporal lobe lesion, which is otherwise not showing any features of aggressiveness on imaging, we can give the diagnosis as polymorphic lesion of the neuroepithelial tumor of the young, that is plenty. Then there come diffuse high-grade pediatric gliomas. So they are again classified into 4 different subtypes. The diffuse midline glioma H3K27 altered. The term which was used in 2016 classification was to H3K27M mutant, but it has been changed to altered now because there are many other molecular and genetic abnormalities seen in these tumors. So the term has been changed to H3K27M altered. Then there is diffuse hemispheric glioma, H3G34 mutant. Then there is a pediatric high-grade glioma, which is not mutant or which is wild type for both histone and IDH mutations. Then there is infant type hemispheric glioma. So let's see these tumors one by one. This is a typical midline glioma. The diffuse midline gliomas can involve any structure of the midline starting from the corpus callosum. So the corpus callosum can be involved, thalami can be involved, the brainstem can be involved, the cerebellar peduncles can be involved, even the vermis and the spinal cord can be involved. So all these tumors and the septum pellucidum, all these tumors will be called as diffuse midline gliomas. And on histochemistry, if the H3K27M gene is found to be positive, then whatever the histopathological or histological morphology of the lesion is directly upgraded to grade 4, because the presence of this mutation makes these lesions so aggressive that they are very prone for dissemination, metastasis, and the survival is very less, of the order of 9 to 11 months only. These tumors are not only seen in pediatric age group, they are seen in adult age group as well. So how these tumors are differentiable from diffuse astrocytoma MIB altered that we saw earlier, the simple looking DIPG, diffuse intrinsic pontine glioma, which is radio responsive. So how to differentiate these tumors? Initially, there were not much papers in the neuroimaging to differentiate these H3K27M mutant tumors from other tumors. But there are certain features like the tumor will be more heterogeneous. T2 flare hyperintensity will be there, but it will be more heterogeneous. It will be diffusion. It will show dense diffusion restriction, as we can, it's not shown here, but on perfusion, as we can see here, bright ASL signal is there. That means it has high perfusion. And on post-contrast images, we can see that there are areas of solid, intense enhancement within the lesion. So these are the characteristic features of H3K27M mutant diffuse midline glioma. Again, a bithalamic tumor is supposed to be having the positive H3K27M mutation mostly. Then we are seeing here another example, a 7-year-old child who presented with seizures. What we are seeing here is a lesion, a large lesion centered in the temporal lobe on the right side. It's a flare hyperintense lesion. The posterior margin appears to be well defined. There is not much edema, but a lot of hemorrhage is there. Central necrosis is there. And on diffusion, the periphery, the margins of the tumor are restricting markedly. But what we are seeing here on ASL, again, this lesion is not bright on ASL and is showing areas of hypointensity. So that means the lesion, whatever aggressiveness it is showing on the conventional MRI, the same thing is not replicated on the perfusion MRI. So this is also a feature of high-grade pediatric tumor, a hemispheric high-grade pediatric tumor, which is H3G34 mutant, where the diffusion restriction will be there, necrosis hemorrhage will be there, but perfusion and enhancement will not be there. So the lesion is high-grade, still there is no high perfusion, still there is no enhancement within the lesion. So this is an example of pediatric hemispheric glioma, H3G34R mutant. Now, the H3K27M altered high-grade gliomas, as I told you, it can be seen in the pediatric as well as adult age group, and the bithalamic lesions are common in this particular subgroup of the tumors. So previously, as I told, there were not many papers for imaging differentiation of diffuse midline gliomas from the mutant gliomas from the wild type gliomas. So we have published the longest series of 123 cases. It's the longest series in the world. It's from NIMHANS, and we have published both conventional features, MRI features, and the advanced MRI features to differentiate between these two tumor groups, the HTK27M mutant from the wild type groups. As I'm showing here in an example, these are two sets of tumors. Both are bithalamic, but both are looking different on imaging. And how it is so that the lesion here we are seeing is very well defined. It is defined within the thalamus. There is not much edema around this lesion, as we can see in the T2 and in the T1 images here. Even on the FLAIR, we can see only a minimal rim of edema here. On post-contrast images, what we are seeing here, there is a thick, solid enhancement with areas of necrosis within the lesion. The necrosis within the lesion shows the aggressiveness of the lesion. So the intense enhancement and the solid thin pattern of enhancement is characteristic of H3K27M mutant lesion. Now, a wild type lesion, what it will show ill-defined margins as opposed to the well-defined margins of a mutant lesion. The marked edema will be there. The edema may involve the entire even hemisphere. Even if the lesion is localized in the midline, the edema can be very well away from the tumor. The tumor can infiltrate the cortex also, the adjoining cortex. Wild type glioma. And you can see here on this post-contrast image that there is no enhancement within the lesion. So these are the characteristics of a wild type lesion, and that's how we differentiate on conventional MRI between a mutant and a wild type lesion. Then another paper we published on the diffusion and perfusion imaging biomarkers, differentiating between these tumors. And again, thalamic tumors, this is the same tumor. What we can see here is on diffusion that the tumor is markedly restricting and there is high perfusion within the tumor, as we can see here from this peak of RCBB in the tumor as compared to the normal appearing white matter, where there is no peak. In contrast, what we are seeing here is again in edema, a tumor having edema, ill-defined margins, no diffusion restriction, there is no high perfusion in the tumor. As we can see here that the peak of the white matter and the tumoral regions is similar. So that's how on advanced MRI we differentiate between a HTK27M mutant midline glioma from a non-mutant glioma. Now, next and the last entity in the pediatric type gliomas is infant type hemispheric gliomas. So these are also very characteristic lesions. These are usually seen in neonates and infants, very large, almost hollow hemispheric lesions. There will be a lot of hemorrhage. The lesion will be highly heterogeneous. Even on T2, you can say that there is a lot of hemorrhage within the lesion. Even the blood can go outside the meninges, and there is less edema. The lesion will cause midline shift and all that, but the lesion will be resectable and will respond to radiotherapy. Now, other than the adult and pediatric gliomas, there are certain other gliomas, that is circumscribed astrocytic gliomas, which include high-grade astrocytomas with pyloid features and astroblastoma MN1 altered. So astroblastomas, they are superficially located lesions, usually cortical based. Bubbly sort of appearance will be there on T2 images. There will be mild edema around the lesion. No diffusion restriction will be there, but the lesion will show bright enhancement on the post-contrast images. So this typical bubbly pattern of T2 appearance and intense enhancement without diffusion restriction is characteristic of these astroblastomas MN1 altered. Now, coming on to the glioneuronal tumors. Amongst the glioneuronal tumors, the imaging and the pathologic classification of ganglioglioma, DNET, the DIG, they have not changed much, but certain new tumor entities have been included in the newer WHO classification, that are diffuse glioneuronal tumor with ODG-like features and nuclear clusters, that is DIGONC, the MGNT, that is myxoid glioneuronal tumor, and the MVNT, that is multinodular and vacuolating neuronal tumor. So let's see a few examples of the conventional glioneuronal tumors. This is an example of a DNET, which is typically a peripheral cortical based lesion, which is the base is towards the periphery, the apex is towards, it's usually a triangular shaped lesion, the apex is towards the ventricles. It will also show a bubbly sort of appearance. On FLAIR, the cysts will invert. It will be diffusion non-restricting. There will be not much enhancement within the lesion. And DNET in the temporal lobe is one of the most notorious lesion to cause seizure that are refractory to medications. So the typical appearance is usually very easy for us radiologists to make a diagnosis of DNET. Another example, this is a typical ganglioglioma with a typical cyst with a nodule configuration. As we can see here on this post-contrast image, that there is a large cyst sitting over here in the parietal lobe, and there is a small mural nodule within the lesion with some few septations which are also enhancing. The same thing we can see here on these T2 and FLAIR images, that there is a septa which is hyper intense, then there is some nodular soft tissue thickening here, which is hyper intense on FLAIR and hyper intense on T2. There is some edema on T2 and FLAIR, and that the typical configuration is of cyst within a nodule. So in a patient who presents with seizure, there are very less differentials for a cyst with a nodule configuration, and ganglioglioma is one of the most common of them. Then this is a third lesion, a large lesion in a child, and involves more than 2 or 3 lobes of a single hemisphere. A large lesion, again with cyst with a nodule or cyst and solid component within the lesion. The solid component will be pial based. There can be, on post-contrast images, there can be a dural tail also associated with the lesion. There will be a lot of edema around the lesion. The diffusion will be markedly restricted in the solid component of the lesion. So this is an example of DIG, or desmoplastic infantile ganglioglioma. The imaging, there is not much changed imaging of these typical conventional glioneuronal tumors from before. Now there are certain new entities like MGNT and MVNT, which has been described in the new WHO classification. So I will show some examples of those entities. So this is a first example, the first 2 images, the T2 and the FLAIR image, where we can see a T2 hyperintense lesion in the periventricular white matter on the left side. Now this lesion is showing again a FLAIR hyperintense rim. So that is a very characteristic feature of MGNT, that is myxoid glioneuronal tumor. First is its site. The most common site is septum pellucidum. The other sites are corpus callosum and periventricular white matter. In these locations, if we see a tumor which is T2 hyperintense and is showing a FLAIR hyperintense rim with central hypointensity on FLAIR, we can call the lesion as MGNT. Another example, on this T1 weighted SAG image, we can see that there is a septum pellucidum, or a lesion arising from septum pellucidum in the region of rostrum of the corpus callosum. And the lesion on axial image here, we can see that the lesion is T2 hyperintense. On the FLAIR, again, we can see that there is a hyperintense rim there around the lesion. The lesion will be non-enhancing. It will not show diffusion restriction. It will not show hyperfusion. So that's how we make a diagnosis of MGNT. Now, other tumors that are described newly described are MVNT. The MVNT is a multinodular and vacuolating tumor. Initially, in 2016 classification, also this entity was there, but it was then described as a pattern of ganglion cell tumor. And whether it was in neoplastic process or a malformative process, that was not known that time. But now in the WHO 2021 classification, they have graded this tumor as a WHO grade 1 tumor and classified it separately in the group of glioneuronal tumors. So this is a typical appearance of MVNT. It sits at the base of a sulcus or in the subcortical region, and it surrounds the sulcus with these cystic nodules. So another example, again, the lesion is sitting at the base of a sulcus. It surrounds the subcortical white matter and the sulcus with some small cysts, as we can see here on this T2 weighted image. There will be no FLAIR inversion of these cysts. The cyst will be hyperintense on FLAIR again. There will be no diffusion restriction. There will be no enhancement, no bleed, and more clearly we can see on this coronal image that the lesion is subcortical with multiple cysts around the lesion. So this is an example of MVNT. Now coming on to the next group, that is ependymal tumors. In 2016, there were 4 groups: the subependymoma, myxopapillary ependymoma, ependymoma, and anaplastic ependymoma. But this type of division is nullified now, and in the recent classification, the ependymal tumors or the ependymomas are basically divided on the basis of their site. So 3 sites are defined, that is supratentorial, posterior fossa, and spinal. Now supratentorial have been further divided based on the molecular, the gene involved, that is ZFTA fusion positive and the YAB1 fusion positive. So basically the morphology of these supratentorial ependymomas is similar, whether the ZFTA fusion positive it is or YAB1 fusion positive it is. The group PFA, PFB, the imaging is similar. The only difference is in the side, that the PFA tumors are more lateralized to the cerebellar hemispheres, and the spinal ependymoma, MICN, is slightly different as compared to the conventional ependymomas that we used to see earlier. So let's see them one by one. This is a large supratentorial tumor, heterogeneous solid cystic, characteristically ependymoma anywhere in the neuraxis, whether it is supratentorial or posterior fossa or spinal. It is characteristically heterogeneous. It will have a lot of blood. It will have cystic areas, necrotic areas. It might have calcifications. So a heterogeneous tumor anywhere in the neuraxis and within the particular age group should suggest the diagnosis of a ependymoma. So this is an hemispheric tumor, solid cystic. Lot of blood is seen on the SWI images. The solid component is showing intense enhancement. This is an example of supratentorial ependymoma. Then again, as I told, the PFA and PFB, that is the posterior fossa ependymomas, they are differentiable based on the age group involved and the lateralization within the cerebellar hemisphere. The PFA ones are seen in infants and they have worse prognosis, while the PFB ones, they are seen in older children and adults, and they have comparatively better prognosis as compared to the PFA ependymomas. The typical posterior fossa ependymoma, it's sort of a plastic tumor. It will be seen either arising from the floor of the fourth ventricle, and it will go into the foramen of Megendie, in the foramen of Luschka. It can surround the basilar artery. It can go into the prepontine cistern, the cerebellopontine cistern. It can show diffusion restriction, but it will be highly heterogeneous. There will be heterogeneous enhancement, and we can see the extension of the lesion going here and there. It will be more plastic sort of lesion in the sense that it goes here and there. That's how we differentiate this lesion from the other posterior fossa lesion in the pediatric age group like medulloblastoma, based on the plasticity of this lesion. Now, spinal ependymoma, that is the newest described spinal ependymoma with MYCN amplification. On imaging, it is usually seen in adult patient. On imaging, it will be a long lesion which will be extramedullary, as we can see here that it is extramedullary, or if the lesion is intramedullary, then it will have a marked exophytic component. It will go over a large number of spinal segments. Again, it will be heterogeneous like any other ependymoma in the neuraxis, and that's how we diagnose a ependymoma in the spinal cord which has MYCN amplification. Now, embryonal tumors. In embryonal tumors, the PNET term was omitted in 2016 classification. Medulloblastoma were molecularly defined in that classification. The differences are that there are certain newer entities as well as the histologically defined medulloblastomas. They are grouped together, and the SHH activated medulloblastomas have been divided into TP53 wild type and mutant subgroups in the newer classification. So the WNT group tumors, they basically arise from the cells embryologically that arise from the lower rhombic lip. So these tumors are usually seen in the locations where these cells are there. For example, the dorsal brainstem, the cerebellar peduncles, the CP angle cisterns, the foramen of Megendie and Luschka, rather than a conventional description of a medulloblastoma, where the medulloblastoma was usually described as a roof of fourth ventricular or a Vermean lesion. So these are 4 different examples of a WNT activated medulloblastomas. So here is a lesion that is sitting over a CP angle, but it will show all other features of a typical medulloblastoma of restriction, diffusion restriction, enhancement, hypointensity on T2 because of its cellularity, and the hyperdensity on CT, the intense enhancement, all those features it will show like that of a typical medulloblastoma. The only difference will be the site of the lesion. So it's a lesion which is centered on the CP angle. It's the lesion which is centered in the foramen of Megendi region and in the cisterna magna region. This is a lesion which is centered in the foramen of Luschka region, and this is a lesion which is centered in the fourth ventricle. So these all are the types of WNT activated medulloblastoma depending upon the location of their cells of origin. Now, the one thing about WNT activated medulloblastoma is that it is having very good prognosis, and they comprise approximately 10% of the medulloblastomas. They are very radio responsive. So if we tell that this particular medulloblastoma is WNT activated, then based on the neuroimaging report itself, sometime they can start the radiation therapy, and then this can help in demulking of the tumor. So that's where the importance of neuroimaging comes. Then the other group is SHH activated T53 wild type and the mutant groups. So these both groups will have almost similar imaging features. The medulloblastoma will be hemispheric in location because they arise from the granule neuron progenitor cells in the upper rhombic lip. And here is an example: a left cerebellar hemispheric lesion, a large lesion, heterogeneous lesion, typically showing all the features of a medulloblastoma, intense enhancement, areas of hypointensity on T2 because of cellularity, as well as because of blood. There is a lot of blood on SWI, and we can see the hyperdensity on the CT. So it's a SHH activated medulloblastoma. Now, the SHH activated TP53 mutant medulloblastoma is the rarest type of medulloblastoma and has worst overall prognosis. But on imaging, we cannot differentiate between the mutant and the wild type. So that is a pathological and molecular diagnosis. And on imaging, these both type of tumors look alike. Now, there is a third group, that is non-WNT, non-SHH group. They are the most common groups of medulloblastoma, and they can be seen anywhere in any location. And initially in the 2016 classification, they were divided into group 3 and group 4 tumors. So but the lesion, they are characterized by minimal or no enhancement. So that is the most characteristic features of these lesions. The all other features will be like that of a typical medulloblastoma, a solid lesion with few areas of necrosis. And the enhancement will be very minimal in these lesions as opposed to a conventionally described medulloblastoma. The diffusion restriction will be marked, the perfusion will be marked. Now, in other CNS embryonal tumors, the morphology of ETMR on imaging is important because they are supratentorial lesions, and their differentiation from large supratentorial lesions like supratentorial ependymoma and astroblastoma becomes important. So, and DIG becomes important. So let's see the imaging of this lesion. So what is the differentiating feature? That's how we can differentiate these lesions. So they will have less edema. They will be involving a lobe, almost an entire lobe, not the hemisphere per se, as in other lesions like in DIG or in the embryonal astrocytoma that we saw earlier. Infantile type hemispheric glioma that we saw earlier. There will be bleed within the lesion, not much necrosis will be there, not many cystic areas will be there. There will be no much enhancement. On ASL, we can see there is not much perfusion within the lesion, but the diffusion restriction will be there. So that's how we describe ETMR on imaging, and that's how we differentiate it from other large hemispheric lesions in children. Now, penial tumors classification has largely been unchanged in the WHO 2021 classification. Only one exception is there, that they have added a new entity, that is desmoplastic myxoid tumor of the penial region, SMARC CB1 mutant. But one point here I would like to say about penial tumors, that with the neurosurgeon point of view, whatever diagnosis we give, whether intrinsic pineal tumor or a pineal region tumor, that is not much important, that does not carry much importance for them, because most of the pineal region tumor, they look alike, especially if they are arising from the pineal cells themselves. Like if there is a papillary tumor or a pineal tumor, or pineoblastoma, or a germ cell tumor, most of them will look alike. There will be a few differences between them based on imaging, and mostly it is differentiated based on the dissemination. The most important thing which they want from us, the surgeons, they want from us, neuroradiologists or radiologists, is that the relation of the tumor with the veins surrounding that region, that is internal cerebral vein or basal vein of Rosenthal, all those things are important there from the resection point of view and from the further treatment point of view. So this newly described entity, the imaging features is like that of other pineal tumors. It doesn't matter whether we write in the report the histological cell type of the tumor or not, and it is not relevant in any of the pineal tumors actually. Then the next group is mesenchymal and non-meningothelial tumors. The meningeal tumors like meningiomas have largely been unchanged in the recent classification. The only major change in the WHO 2021 classification is that with soft tissue tumors, that is the solitary fibrous tumors and the hemangioparasitoma subgroup, where hemangioparasitoma terminology has now been omitted, and all the tumors which look like hemangioparasitoma are now called as solitary fibrous tumors, and they correspond to the extracranial counterparts of themselves, the solitary fibrous tumors. So they are the most common non-meningothelial mesenchymal neoplasms. They can be graded from grade 1 to grade 3. The term hemangioparasitoma, anaplastic hemangioparasitoma, all these terms are omitted, and the imaging features are largely that of meningiomas in these lesions. Now, in the tumors of the sellar region, not much change again is there. The pituitary adenomas have just been given a new name, that is pituitary adenoma or pituitary neuroendocrine tumor, to correspond to systemic neuroendocrine tumors. And there has been described a new entity, that is pituitary blastoma, which is on imaging wise, it is similar to any other blastoma in the brain, like pineoblastoma or retinoblastoma or any other blastoma which we see in any other body, the typical round blue cell tumor, which enhances intensely, which restricts markedly, and which is having high perfusion parameters. So imaging wise, not much changes there. Now, this blastoma, it's a rare embryonal cellular neoplasm of infants, and it's a WHO grade 4 tumor, as like that of other blastomas in the neuraxis. So this is an example of a post-contrast sagittal and coronal image of this tumor. The intensely enhancing tumor, the cellar and the supracellar component. There is a cystic component as well in this tumor. The tumor is well defined. In these images, we are not able to see any kind of dissemination. But since it's a grade 4 tumor, and it is therefore highly notorious for showing dissemination, like that of other embryonal tumors. Now, so these were the findings, the imaging findings in the newer tumor entities described in the WHO classification. So the summary, or I can say the take-home message here is that for the radiologists and neuroradiologists, they should be familiar with the updated WHO classification of CNS neoplasms to function appropriately as a part of modern neurooncology clinical team, and especially radiological reports should give a brief idea of any molecular pathology if they are able to discern on the basis of imaging features. So that here I will end my talk, and thank you the organizers for letting me speak here. Thank you so much. Any questions, if they are I most welcome.
Thank you, Dr. Richa, for such an informative session discussing about the imaging features of various CNS tumors. This is very important for us as pathologists for correlating with the radiological diagnosis and giving an integrated layered diagnosis with more accuracy. Thanks a lot. There are no
thank you
questions.
so much, Dr. Garima.
Thank you, ma'am. Now I request Dr. Tarang Patel, sir, Assistant Professor, Pathology Department. I request sir to continue this session. Thank you, sir.
Okay, so thank you. So topic is okay. So pediatric diffuse low-grade glioma, PDLGG. So this is new category which has been included into the latest WHO 5th edition 2021. Previously, in previous edition of 2016, there was no such category. Till the last edition, the gliomas were classified based mainly on morphology. But now, with the emergence of NGS, next generation sequencing technique, now the classification of glioma is based on genetic standards. This 5th edition is based on modification done on 2016 classification, and it is based on recommendation of the C-impact. C-impact means consortium to inform molecular and practical approaches to CNS tumor taxonomy. Now, these are the few highlights of 2021 classification. There are total 22 new CNS tumors entered compared to 2016 edition, and 13 CNS tumors have been renamed. Their names have been changed, altered. In new classification, Arabic numerals are used instead of Roman numerals to rule out any typographical error. In new edition, anaplastic term has been removed and neoplasms are graded within tumor types. Means previously there was anaplastic astrocytoma, but now it is termed as a diffuse astrocytoma grade 3 or ADS mutant adult glioma grade 3. Then in present edition, diagnosis and grading is based on combined molecular and histopathology. It means even if the tumor is not showing grade 4 changes, but if it is showing molecular features of grade 4, then tumor is given as a grade 4 glioma. And in new edition, quantification as mitosis is done. Previously, mitosis is given per hyperfield, but now onwards it is given per mm square. And now every category has been designated 2 criteria: essential and desirable diagnostic criteria. And 2 new terms have been added: NOS and NEC. Not otherwise specified is used when required diagnostic information or diagnostic technique is not available for WHO diagnosis, and not elsewhere classified is used when the required diagnostic information is available but
Hotspot.
Okay. So welcome back. So there was some network issue. So we were at NEC. Not as well classified is used when the diagnostic information is available, but it does not allow a given designated WHO diagnosis. So these are the new 22 CNS tumors, but today we will talk about only first 3 tumors. These 22 tumors include 7 glioma, 3 glioneuronal, 4 ependymoma, 4 embryonal, 3 sarcoma, and 1 pituitary tumor. And the new 7 glioma are 3 from pediatric type diffuse local glioma, 3 from pediatric type diffuse high glioma, and 1 from circumscribed glioma. Pediatric type diffuse local glioma, PTLGG, it includes 3 new tumors in this edition. Diffuse astrocytoma, MIB-L1 altered, plenty means polymorphous low-grade neuroepithelial tumor of the young, and diffuse low-grade glioma, MAPK altered. And 1 tumor is from the previous edition, that is angiocentric glioma. Now, diffuse astrocytoma, MIB-L1 altered. Essential criteria is diffuse astrocytoma without anaplasia, absence of IDH or S3 mutation, and structural variant of MIB or MIB-L1 alteration. Desirable criteria is absence of OLIC2 and MAP2 expression. It is basically located in cortical and subcortical component, and the temporal lobe is most commonly involved. Clinically, it presents with drug-resistant epileptic seizures in childhood, and microscopically, it shows diffuse proliferation of monomorphic glial cells with round to oval nuclei and fibrillary matrix. Sometimes it is difficult to differentiate it from the normal parenchyma. It means we cannot designate it as a neoplasia because of minimal cellularity and atypia. But focus of entraped neuron is a sign of neoplasm. Mitosis is minimal, and focal angiocentric pattern may be seen. It means angiocentric glioma and MIB-L1 altered, they both can show overlapping morphology. So this is the picture showing minimal atypia with monomorphic bland glial cells. Here image A is showing monomorphic glial cells, image B is showing strong diffuse GFAP positive, image C and D showing minimal atypia with entraped neurons. Here image A is OLIC2 negative, image B SOX10 negative, image C MAP neurofilament, and image D MAP2 negative with few positive entraped ganglion cells. So on IHC, GFAP positive, very low Ki67, negative for MAP2, OLIC2, CD34, SOX10. So in contrast to adult low-grade glioma, it is OLIC2 negative because adult low-grade glioma is OLIC2 positive. It is IDH negative, whereas adult glioma is IDH positive. ATRX expression is retained, whereas adult glioma shows loss of ATRX. So differential diagnosis can be adult type glioma and angiocentric glioma. Angiocentric glioma can show morphology similar to this type. However, molecular pathology is typical for angiocentric glioma, whereas adult type glioma is positive for IDH1. So on molecular pathology, alteration of MIB or MIB-L1 and fusion with MAML2, MMP16 and PCDG-HA1. Whereas in angiocentric glioma, fusion partner is QKI. And it is clinically benign lesion and CNS WHO grade 1 tumor. Now next tumor, angiocentric glioma. Essential criteria is a diffuse growth with local angiocentric pattern and a monomorphic spindle cells with astrocytic and ependymal differentiation. Desirable criteria are lack of anaplasia, MIB alteration, and MIP or MIP admin alteration on methylation. Common location is cerebral with clinical presentation of chronic intractable partial epilepsy. On microscopy, we can see monomorphous bipolar spindle cells arranged in typical angiocentric pattern. So there is a tumor cells arranged around cortical blood vessel. Sometimes ependymoma-like pseudorosets may be seen. There is no signs of high-grade tumor like mitosis or microvascular proliferation or necrosis. So image A is showing elongated cells with minimal atypia. Image B is showing typical perivascular or angiocentric pattern, and image C is showing syncytial pattern with occasional enteral neurons. Here image A is showing perivascular iron tumor cells positive for GFAP. Image B is showing typical dot-like EMA positivity. So this dot-like EMA positivity is present only in angiocentric glioma, whereas other three tumors of this category does not show EMA positivity. Only 2 negative and NFP staining exons. So on IHC, GFAP positive, dot-like EMA and OLEC2 negative. So it typically shows typical molecular pathology with QQI fusion, and it is a low-grade tumor, CNS WHO grade 1 tumor with favorable prognosis. So third tumor is plenty polymorphous low-grade neuroepithelial tumor of the young. Essential criteria are diffuse growth pattern, oligodendroglioma-like components, ODG-like component, scanty mitosis, strong CD34 expression, IDH wild type, and BRAF mutation on IHC or molecular method. So CD34 positivity is the typical picture of this tumor, because other three tumors of this category, they do not show strong CD34 positivity. So whenever in children, we can, if we see oligodendroglioma like morphology, then we should keep in mind plenty tumor. And the desirable feature is conspicuous calcification. However, 1p19q co-deletion is absent in contrast to adult type oligodendroglioma. So it is cortical and subcortical in location. 80% tumor occurring temporal lobe. Clinically, it presents as a refractory epilepsy. Calcified area are hypointense on MRI, whereas non-calcified area is T2 hyperintense. Microscopically, ODG-like components seen with small round nuclei and perinuclear halo, and focal astrocytic component may be seen. So calcification are present in large majority of cases, and this finding is helpful in children to diagnose this entity. These all features are absent: necrosis, MVP, gemistocyte, myxoid, microcyst, neurocytes, Rosenthal fibers, and absence of all these features helps to rule out differential diagnosis and other mimicking tumors. Okay, next. Next. So here image A is showing previous one. Yes. Okay. So here image A is showing ODG-like morphology with typical nuclear feature and chicken wire calcification. Image B is showing mild nuclear atypia. Image C is showing astrocytic component. Image D is showing perivascular ionization, and image E is showing typical large confluent calcification. Next. Here image A is showing ODG-like cells. Image B is showing calcification. Image C is showing typical strong and diffuse CD34 positivity, which is typical of this tumor. Image D is showing OLEC2 positivity. So you can see OLEC2 was negative in previous two tumors, MIB L1 altered and angiocentric glioma. However, it is positive in plenty. Ki67 is less than 2% and IDH is negative. Next. So on IFC, it is GFAP and olecto positive, CD34 diffuse and intense, ATRX expression is retained. BRAF is positive in few cases, whereas it is negative for IDH1, EMA, synapto, and chromo. Next. For differential diagnosis, diffuse astrocytoma, which is CD34 negative and it is showing IDH mutation, where an adult oligodendroglioma which shows 1p19q correlation. Next. Molecular pathology show MAPK pathway alteration, which includes BRAF, B6 entity mutation, and fusions involving FGFR2 and FGFR3. However, it is negative for IDH, ATRX, or 1p19q correlation. Prognosis of this tumor is very good with CNS WHO grade 1. Next tumor, diffuse low-grade glioma, MAPK pathway altered. This is the fourth and last tumor of this category. Essential criteria are diffuse glioma with absent or minimal mitosis and without microvascular proliferation and necrosis. Genetic alteration in MAPK pathway, IDH and H3 wild type, along with absent homozygous deletion of CDK and 2A. This homozygous deletion of CDK and 2A is important because circumscribed astrocytic glioma like pleomorphic xanthoastrocytoma and high-grade astrocytoma with pyloid feature, they both are showing deletion of CDK and 2A, but here it is absent. And desirable criteria are onset in childhood and absence of morphological features of any other tumor which contains FGFR or BRAF mutation. Predominant location is cerebral hemisphere, and the clinical feature is long-standing epilepsy along with headache, nausea, and vomiting. On microscopically, these tumors are typically not showing any distinctive morphology. They are usually having blind appearance. Next. Now they are again divided into two types: FGFR1 altered and BRAF mutant. FGFR1 altered entity, it shows ODG-like morphology with some overlap with desembroplastic neuroepithelial tumor. This entity shows minimal necrosis and MVP. OLIC2 is positive with only focal CD34 positivity, whereas plenty is showing strong diffuse CD34 positivity. So differential diagnoses are DNET, which is showing typical morphology, PLNTY, which is showing strong CD34 positivity, and adult type oligodendroglioma, which is usually IDH mutant. BRAF mutant, BRAF mutant shows well-differentiated blind cells with blind nuclei. However, it is negative for Rosenthal fibers or eosinophil granular body. So, absence of Rosenthal fibers and EGB, it helps to rule out pilocytic astrocytoma, pleomorphic xanthoastrocytoma, and ganglioglioma. This tumor is OLIC2 positive with BRAF positive IFC. Next. So here morphology shows moderate cellularity in image A. Image B is showing few enterope neurons, and image C and D are showing subpile aggregation of the tumor cells. Here you can see tumor showing two different type of morphology. Sometimes it can show astrocytic morphology when it is associated with BRAF mutation, and it shows ODG-like morphology. Next. So on IFC, GFAP, OLIC2, and BRAF are positive. Corresponding images showing positive GFAP, OLIC2, and BRAF on IFC. So on molecular, there are alteration of MAPK pathway, and the common genetic alterations are BRAF and FGFR1, with rare alteration in FGFR2, NTRK1, NTRK2, and NTRK3. So in future, it is possible that this MAPK pathway altered tumors may be categorized into some specified categories. And sometimes in future, novel target therapy may be helpful to change the prognostic and predictive values, because BRAF mutant types may respond to BRAF inhibitors, and FGFR1 altered type may respond to MEK inhibitors. So this is the molecular approach to diffuse glioma. If glial cells are showing IDH mutation with ATRX mutation, then it is IDH mutant glioma grade 2 and 3. And if it is accompanied by deletion of CDK and 2A or B, then it is grade 4. If there is an IDH mutation with 1p19p correlation, then it is oligodendroglioma. If there is a IDH wild type with EGFR amplification or third mutation or 7 addition and 10 deletion, then it is glioblastoma. If there is a IDH wild type with mutations in H3, PDGFR, EGFR, MECAN and RTK, then it is pediatric type high-grade glioma. If there is a IDH wild type with MYB or MYB alteration and MEPK pathway alteration, then it is pediatric type diffuse low-grade glioma. So this is summary of this lecture PDLGG. There are 4 types. All types are on radiologically mostly T1 hypo and hyperintense on T2 flare, except on plain T, which is showing calcification. All are so this was the last slide. So all 4 are showing typical molecular pathology. All 4 tumors are low-grade tumors. First 3 tumors are grade 1, CNS WHO grade 1 tumors, whereas in 4th tumor, WHO grade is yet to be assigned. Okay, thank you. Any question?
Thank you, Dr. Tarang sir, for such an interesting and informative talk. Now I request Dr. Garima Anandani ma'am, Assistant Professor Pathology Department from IMS Rajkot, to continue this session with her presentation. Thank you, ma'am. Over to you.
Okay. Today my topic is on update in embryonal tumors of the CNS. Okay, according to the recent WHO classification, we'll just discuss about the embryonal tumors update. So I'll just show what was the 2016 WHO classification. According to 2016, medulloblastomas genetically defined were divided into 4 categories: WNT activated, SHH activated, TP53 wild type, SHH activated, TP53 mutant, and non-WNT, non-SHH group 3, group 4. The other category was histologically defined, which comprised of classic desmoplastic nodula with extensive nodularity and large cell anaplastic medulloblastoma. Other than that, we had embryonal tumor with multilayered rosettes, C19MC altered, other CNS embryonal tumors like medulloepithelioma, CNS neuroblastoma, atypical teratoid rhabdoid, and CNS embryonal tumor with rhabdoid features. Now, presently, according to the 2021 classification, medulloblastomas are first divided into 5 categories. The first 4 categories are the same genetically defined, which are WNT activated, SHH activated, 53 wild type and mutant, and non-WNT, non-SHH. Now, all the histologically defined categories have been comprised in one category itself, named as medulloblastoma histologically different. Okay, other than that, the other CNS embryonal tumors, we are having 2 new entities, which are FOXR2 activated CNS tumor with B4 ITD, and one provisional entity is cribriform neuroepithelial tumor. Okay, along with that, there is an entity which is having a new name, that is embryonal tumor with multi-layered rosettes. Previously, it was ETMR with 19MC mutation, but right now it is named as just ETMR. Now, medulloblastomas are separated with SHH activation in different groups, as I showed you, based on the TP53 status. ATRT has been divided into 3 molecular subtypes, SHH, MYC, and PYR, that is a tyrosinase. And embryonal tumors with multi-layered rosettes, along with the 19MC mutation, they also comprise the DICER1 mutations now. As I showed you, 2 new entities, names neuroblastoma FOXR2 activated and CNS tumor with B4 ITD duplication has been added, and provisional entity named cribriform neuroepithelial tumor. Now we will see this short about medulloblastoma. It is the most common CNS embryonal tumor, representing greater than 90% of all the cases, and usually it is seen in the cerebellum or dorsal brainstem. 77% of the cases occur before 19 years of age, 10 to 15% of the cases occurs in infant, and rarely it can be seen in adults, usually in the 21 to 40 years of age. 30% of cases show CSF metastasis at presentation. Now we go to the histopathology of the classic type. They will be highly cellular, molding of nucleoli will be seen, brisk mitosis, karyorrhexis will be there. There will be focal tumor necrosis, but there will be no palisading pattern of glioblastoma. Vascular endothelial proliferation is unusual, but even if it is present, it will not exclude this diagnosis. There can be neuronal differentiation, hemorrhoid rosettes, and streaming will be seen. Here you can see the nuclear molding, and some hemorrhoid rosettes will be there, as well as the streaming will be seen. Then the next morphological type is desmoplastic nodular, usually occurring in less than 3 years of age. Mostly it is seen in the cerebellar hemisphere. There will be foci of differentiation, pale islands of increased cytoplasm and neuropil formation will be there. Background will be reticle enriched, highly cellular, proliferative, and these will be positive for neuronal markers, specifically synaptophysin and mu-n, and to some extent GFAP markers as well. This is the morphology. As you can see, there are nodular pale islands, and there will be internodular hypercellular areas will be seen. The hypercellular internodular areas will contain abundant reticulin, and these areas will be will have high Ki67, that is the MIB1 index. Now the next one is medulloblastoma with extensive nodularity, almost exclusively in infants. There will be reticulin free pale areas of differentiation. These areas will predominate in this category. It is having very good prognosis. SHH pathway mutations can be seen. GAP1 positivity will be there. On CT scan, you can see bunch of grape appearance will be there, and on microscopy, the pale islands will be more over here. They will be predominating, while the internodular zones will be devoid of cells, devoid of primitive elements. You can see there will be rows of mature neurocyte-like tumor cells, and there will be a neuropile-like stroma. Now the last morphological category, that is the large cell anaplastic, comprising of 10 to 22% of the cases. It is an aggressive one, and it will be less responsive to the therapies. It can coexist with other morphological subtypes. There will be anaplasia, bizarre multinucleated giant cells, cannibalism will be seen, apoptotic lakes will be present. As you can see, this is highly cellular. There will be prominent nucleoli, cell wrapping will be there, anaplastic features will be there, high pleomorphism, atypical mitosis, and cannibalism is seen in the C wala picture. Here, they will phagocytose the neighboring cells. Then the rare variants are myogenic and melanocytic differentiation. In the skeletal muscle differentiation, they will be positive for the desmin or other skeletal muscle antigen. And the melanotic or often the retinal pigment epithelial differentiation can also be seen. These are just the morphological patterns with no clear clinical significance. As you can see, there is the myogenic differentiation positive for desmin, whereas the retinal pigment epithelial differentiation you can see in the C picture, and it will be HMB45 positive. Now we go to the genetically defined medulloblastoma groups. The WNT group, usually it is seen in the children and adults. There is no sex predilection in this. Mostly classic, rarely LCA type will be there, and rarely it will metastasize. Prognosis is very good, and MYC positivity is there. CTNN B1 mutation will be present. The SSH group, it can be seen either in the infants or children or adults. Here also there is no sex predilection, and it can be desmoplastic nodular, classic, or LCA type. Uncommonly, it can also metastasize. In infants, it is having good prognosis, while in others, it is having intermediate prognosis. MYC and positivity will be there. PTCH, SMO, SUFP mutations will be seen. Group 3, in this, we are having male predilection, and it can be seen in infants as well as children. It is very frequently metastatizing tumor, having a poor prognosis. Group 4, it can be seen in infants, children as well as adults. This one is also having male predilection. It can be classic or LCA type, frequently metastasizing, and intermediate prognosis. This already we discussed about the WNT, SHH, and non-WNT, non-SHH types of the genetic medulloblastoma cases. The WNT group will be beta-catenin nuclear positive. The SHH activated group will be GAP1 and GAP1 positive. Cytoplasmic positivity will be seen. Both WNT and SHH medulloblastoma groups will be filamin A cytoplasmic positive. And the non-WNT, non-SHH group, it will be showing cytoplasmic positivity for beta-catenin, not nuclear positivity. And it will be negative for GAP1 and GAP1. The various types of nuclear reactivity of beta-catenin can be seen. It can be blanket-like cytoplasmic nuclear, variable nuclear, or strong nuclear staining. If the nuclear staining is less than 2% of the cells, it is not considered as WNT tumor. These are the various types of immunostaining for beta-catenin, which we can see. Now, GAP1 is strong cytoplasmic staining in the internodular regions of the desmoplastic nodular medulloblastoma. Okay. In the non-desmoplastic SHH type, diffuse GAP1 reactivity will be there. It can be weak, so it should be used along with filamin A and or GAP1. The WNT and non-WNT, non-SHH type will be classically GAP1 negative. Now, filamin A will have a cytoplasmic staining similar to the GAP1, and this will be also negative in non-SHH, non-SHH WNT type of medulloblastoma. GAP1 is having a predominantly nuclear along with cytoplasmic staining. Desmoplastic nodular will show a strong GAP1 staining in the internodular tumor cells. Desmoplastic nodular medulloblastoma, along with the medulloblastoma with extensive nodularity, usually they will belong to the SHH molecular subgroup. WNT tumors will have a classic morphology, and most of the large cell anaplastic tumors are included in the SHH3 subgroup or non-WNT, non-SHH group 3-4 subgroup. Now, other CNS embryonal tumors like atypical teratoid rhabdoid tumor, embryonal tumor with multi-layered rosettes, CNS neuroblastoma with FOXR2 activated, CNS tumor with BEAK or ITD have also been added. Cribriform neuroepithelial tumor is a provisional entity. Atypical teratoid rhabdoid tumor is a highly malignant tumor with poorly differentiated cells. Focal or diffuse rhabdoid features will be present. There is biallelic inactivation of SMARCB1 or rarely SMARCA4. Diagnosis relies basically on the histology and IHC. There will be loss of SMARCB1 or rarely SMARCA4. It is again divided into 3 molecular subtypes: SHH, TIRE, and MYC. This is a gross picture. You can see it is a partially necrotic tumor of the cerebellopontine angle and it will be dusky hemorrhagic tumor. This is a morphology. There will be tumor cells having eccentrically placed nuclei, inclusion like eosinophilic cytoplasm, and prominent nucleoli will be seen. There will be loss of INI BAC47 protein expression. As you can see, the internal control will be endothelial and inflammatory cells. Now we come to the provisional entity of cribriform neuroepithelial tumor. Here there will be cribriform strands and ribbons. There will be loss of SMARCB1 expression, usually seen in the periventricular areas. There will be strands and ribbons of basically non-rhabdoid type of cells. There will be strong positivity for EMA and loss of SMARCB1 expression. This is the morphological picture. As you can see, there is a ribbon formation, strands are there, small lumina formation can also be there. SMARCB1 loss will be there. Tyrosine staining will be positive in cytoplasm. Now we go to the embryonal tumor with multi-layered rosettes. Previously, it included only the C19MC mutation at the chromosome 19 locus, but now it has been renamed like embryonal tumor with multi-layered rosettes. This also includes the Dicer1 type of mutation. Histologically, it can be embryonal tumor with abundant neutrophil and true rosette type, or like ependymoblastoma, which will lack the neutrophil, or medulloepithelioma like, whereby embryonal cells with papillary trabecular tubular pattern can be seen. There will be strong diffuse cytoplasmic immunoreactivity for LIN28A. It is a very useful marker for the diagnosis of ETMR. If C19MC alteration is absent, it suggests the presence of Dicer1 mutations. This is a morphological picture. Multi-layered rosetting will be there, abundant mitosis will be there, and it will be positive for LIN28A. This is the fish picture showing amplification of the 19q1342 loci. Copy number variation analysis shows C19MC amplification over here. Now we go to the CNS neuroblastoma, FOXR2 activated. Obviously, this is based on the DNA methylation analysis, which was done on previous CNS PNET type of tumors. This is having a small cell morphology in a background of neuropil, and mixed markers like OLIC2 and synaptophysin will be positive. In addition to FOXR2 alteration, 1q gain and 16q loss is also seen in these tumors. This is the morphology. Primitive small blue cells will be there, nuclear overlapping will be there, oligo-like areas are present with calcification, diffuse synaptophysin expression will be there, diffuse OLIC2 expression will be there. And as you can see, the copy number variation analysis shows gain of chromosome 1q and focal or total loss of 16q. This is the last category, CNS tumor with B-core ITD duplication. This also is based on the distinct methylation profile. It will show internal tandem duplication in the terminal exon of B-core. There will be presence of oval or spindle malignant tumor cells arranged in sheets, ependymal-like perivascular pseudorosettes will be present, and the background can sometimes be myxoid or microcystic, usually seen in the cerebral or cerebellar hemispheres. There will be patchy expression of OLIC2, GFAP, S100, NUN, and synaptophysin. Strong nuclear positivity of B-core will be present. But this is not specific, as it can also be seen in astroblastomas or solitary fiber tumors. So the definitive diagnosis depends on the molecular detection of B-core ITD mutations. This is the morphology. Oval spindle cells can be seen, markedly atypical. Mitosis will be there, myxoid stroma, and strong nuclear B-core expression will be there. Thank you so much for patient listening.
Thank you, Dr. Garima ma'am, for your great presentation. It was very useful. Now I request Dr. Gyanendra sir, Assistant Professor Pathology from AIIMS Rajkot, to continue this session with his presentation. Thank you, sir.
So in this session, we will discuss about the newly updated classification of neuronal and glioneural tumor in the 5th edition of WHO classification of CNS tumor. So this is a 2016 classification of WHO CNS tumor in neuronal and mixed neuroglial tumor. पाँच तक हो गया। So this is the classification of neuronal and mixed neuroglial tumor of 2016. If we compare to the 5th edition of 2021, 3 entities has been included. These are the diffuse glionular tumor with oligodendrioma-like nuclear features and nuclear clustering. Second is myxoid glionular tumor, and third is multinodular and vacuolating neural tumor. This first entity, diffuse glionular tumor with oligodendrioma-like nuclear feature, this is a provisional entity and will be included in the next edition. And this myxoid glionular tumor and multinodular and vacuolated neural tumor are 2 other entities. So we will discuss the newly described entity in this classification. This is a molecular pathway which are included in this neuronal and glionular tumor. If we discuss about this diffuse glionular tumor with oligodendrioma-like nuclear feature, there is a characteristic monosomy of chromosome 40 in DNA methylation study. Along with this new other tumor, myxoid glioblastoma tumor, there is a mutation there is a PDFGRA and multinodular and vacuolated neural tumor. These are associated with mutation in a MAP kinase pathway. So diffuse glionular tumor with oligodendroglioma-like nuclear features. These tumors occur mainly in the children, although higher age group has been described in the literature. They most commonly arise from the cerebral hemisphere, most commonly in the temporal lobe. And the DNA methylation study shows a specific recurrent monosomy 40 on chromosome 40. These tumors, previously the oligodendroglioma hybrid category, oligodendroglioma class 3 and DNET and PNET was considered as a morphological variant of this tumor on histopathological finding, but the presence of this recurrent monosomy in chromosome 40, this tumor is categorized a new entity in this classification. On histopathology, this tumor shows a moderate to diffuse sheet-like appearance of these oligodendroglioma-like cells with this clear perinuclear hollow island of neuropil-like material and this perivascular proliferation, vascular proliferations. On IC, these tumors are GFP negative and so strong positive for neutrophils immunohistochemistry. Second category is myxoid glandular tumor. This tumor occurs in the children and young adult and is represent approximately 2% of all brain tumor. And this tumor is characterized by a genetic mutation in this platelet-derived growth factor receptor A, most commonly located in the septum pellucidum and also the corpus callosum region. These tumors demonstrate low-grade proliferation of oligodendrocytes-like cells in a prominent myxoid or mucin-rich stromas. Immunophenotyping, these show positivity for OLIG2, SOX10, GFAP, and these myxoid glioma tumor is negative for BRAF1, FGFR1 mutations. Ki67 index is low, 1 to 4%, and these tumor is categorized by WHO grade 1 with good prognosis. So this is a histopathological image of myxoid glandular tumor showing these oligodendron-like cells with these pools of mucin and the floating neurons in these pools of mucin. Few rosette-like structures are also noted. Third entity is multinodular and vacuolated neural tumor. It is an indolent subcortical tumor. Although true epidemiology of this tumor is not known, it mostly affects the young to middle-aged individual with adult onset epilepsy. And there is an alteration in MAP kinase pathway in this tumor. On histopathological examination, low power, this tumor shows the multinodular appearance, either discrete or confluent. And on high power, this shows vacuolation in not only the tumor cells, also in the underlying stromas also. DNET, it is the previously described entity in this WHO classification of CNS tumor. We are not describing it, already described in 2016 classifications. Desmoplastic infantile and astrocytoma and oligo and ganglioglioma already described. Gangliocytoma, this is a WHO grade 1. This is also very rare tumors along with this ganglioglioma. Papillary glandular tumor, this is WHO category 1. It is a biphasic tumor which comprises of this thrombosed vessels with lined with these cuboidal tumor cells. And this tumor has a molecularly SCLCL44A1 and PRKCA1 fusion gene. Rosette forming glandular tumor, this is also considered WHO category 1. Diffuse leptomeningeal glandular tumor, this is also rare, usually occur in young children, has a spinal predominantly widespread leptomeningeal growth pattern. This is not currently graded, it is too rare. Central neurocytoma, also categorized in 2016 classification, extraventricular neurocytoma. Cerebral lateral neurocytoma, this is considered WHO category 2 tumors. Thank you.
So any questions from any participant? So thank you, Dr. Ganendra, for such a wonderful session. I hope there is no query. So thank you, Dr. Ganendra. Please say a few words.
So I would like, first of all, I would like to thank our respected director, sir, Executive Director, AIIMS Rajkot, Professor Dr. Colonel CDH Tumours, sir, for providing this opportunity to conduct CME by Department of Pathology. I would like to thank our Dean of Academic, Dr. Vivek Sharma, sir, for their encouraging words toward the initiation of this CME. I would like to thank all the speakers, all the faculty members, all the residents and JRs who registered for this CME, all the external speakers, deliver highly intellectual and informative talks. Our SR, JR, and professional from the IT staff, thank you so much.
Thank you, Alok.
Thank you.